Cardiac output is dependent on all of the events in the cardiac cycle. Cardiac output is the amount of blood pumped by the heart each minute. It's determined by the stroke volume, which is the volume of blood pumped from the ventricle per beat, and the heart rate, or the number of beats per minute. The things that affect stroke volume, and therefore cardiac output, are preload, afterload, and contractility. Preload is the load on the heart muscle just prior to contraction, and it's proportional to the volume of blood in the heart at the end of diastole, or the end diastolic volume. Increased preload causes increased stretch of the ventricular myocytes, optimally aligning actin and myosin, which increases the force of contraction and therefore the stroke volume. Afterload is the load or force against which the ventricle must pump to eject blood, and it's proportional to the systemic vascular resistance. Increased afterload causes more resistance and decreases stroke volume. Contractility is the intrinsic ability of the cardiac myocytes to contract, and it's proportional to the number of actin-myosin cross-bridges that are actually formed based on the intracellular calcium concentration. Contractility is not affected by preload and afterload. When contractility increases, stroke volume also increases. So preload and afterload are load-dependent variables that change based on the volume of blood in the ventricle, while contractility is load independent, and it's the intrinsic ability of the ventricular muscle cells to contract regardless of the volume in the chamber. Changes in preload, afterload, and contractility can each alter stroke volume. A couple of graphs are used to discuss cardiac output as it relates to cardiovascular physiology and cardiac disease. One is the pressure volume curve that shows the left ventricular pressure on the y-axis versus the left ventricular volume on the x-axis. And there are two important curves on this graph. The passive or diastolic curve is the relationship between the volume and pressure in the left ventricle when the heart is relaxed. As the volume in the relaxed left ventricle increases, ventricular pressure only slightly increases through passive mechanisms. And that slight increase in pressure reflects the passive stretch or tension in the ventricular myocytes as they're stretched to longer lengths with larger blood volumes. So if the left ventricle is filled to this volume at the end of diastole, and then the heart was made to contract to reach its maximum contractile force or its maximum tension, it would reach some pressure here. And if that volume was increased and the heart was made to contract again, it would reach a higher pressure here. So as the end diastolic volume increases, the maximum pressure generated also increases. Increasing the volume in the left ventricle leads to more stretch of the ventricular muscle cells, which causes greater overlap of thick and thin filaments, greater cross-bridge formation, and greater tension or pressure developed. These maximum pressures can be connected to make a line, and that is the active or systolic curve. This curve is the relationship between the left ventricular and diastolic volume and the maximum pressure that can be developed during the contraction from that starting volume. It shows that the volume of blood in the heart when it starts to contract, in part, determines how much tension or pressure can be generated, and therefore how much blood can be pumped. This is the basis for the Frankstarling relationship in the heart. The cardiac performance, or the Frankstarling curve, shows how well the ventricle can pump out the blood that it receives. It plots the left ventricular and diastolic volume against a measure of cardiac function, like stroke volume or sometimes cardiac output. So if about 125 milliliters of blood ended up in the left ventricle right before the left ventricle started to contract, then the ventricle would be able to pump out about 75 milliliters of that blood. And if the heart filled even more during diastole and about 210 milliliters of blood ended up in the left ventricle before it started to contract, then the stroke volume would be greater and more like 110 milliliters of blood would be pumped out. The Frankstarling relationship states that the volume of blood that the ventricle pumps out, or the stroke volume, depends on the volume of blood in the chamber at the end of diastole. This is important because it allows the heart to change the volume that it pumps out to match the volume of blood that it receives. So as we saw in the pressure volume curves in the last slide, the reason that this occurs is because the force of contraction is proportional to the length of the ventricular myocyte at the end of diastole. So increasing the volume of blood in the left ventricle at the end of diastole stretches the ventricular myocytes. The actin and myosin filaments line up, allowing more cross bridges to potentially form, increasing the force of contraction and therefore the stroke volume. Depending on the state of the heart, this curve can move up or down on this graph. So, for example, if a heart was stimulated by epinephrine or some other mechanism to increase intracellular calcium concentration, the curve would shift up and to the left. So at the same left ventricular end diastolic volume of 125 milliliters, instead of 75 milliliters being pumped out, in this case, we now have 110 milliliters being pumped out, or our stroke volume is around 110 milliliters. This ventricle is working harder, and it's able to produce a greater force of contraction for a given left ventricular end diastolic volume, pumping out more blood. In a heart that isn't functioning as well, the curve will shift down and to the right. So in this example, the ventricle is receiving that same 125 milliliters of blood just before it begins to contract, but the amount of force produced by the contraction is low. So the heart can only pump out a small volume of blood and the stroke volume is low. The pressure volume loop shows changes in the volume and pressure in the left ventricle during a complete cardiac cycle. Remember that the passive curve shows the passive stretch or tension on the ventricular myocytes at a given volume, and the active curve shows the maximum pressure developed upon contraction for a given ventricular volume. Connecting the passive and active curves gives us the pressure volume loop. So the cardiac cycle is divided into ventricular filling, isovolumetric contraction, ejection, and isovolumetric relaxation. During ventricular filling, the left ventricle fills with blood from the left atrium, passively and actively when the atrium contracts. During this phase of diastole, there's a sharp increase in left ventricular volume while the pressure increases only slightly. There's little pressure change during filling because the ventricle is relaxed and it stretches to accommodate that increased volume. Point 1 is the volume and pressure at the end of ventricular filling or at the end of diastole, and this represents the end diastolic volume and end diastolic pressure for the left ventricle. As the ventricle begins to contract, the ventricular pressure exceeds the atrial pressure and the mitral valve closes. Contraction continues and the ventricular pressure increases dramatically. Since all the valves are closed, blood can't be ejected and the ventricular volume remains constant during this phase of isovolumetric contraction. Point 2 is where the left ventricular pressure exceeds the aortic pressure, causing the aortic valve to open. Notice that during contraction, the left ventricle does not reach the maximum pressure possible for that given end diastolic volume. The reason for this is because when the ventricular pressure rises above the aortic pressure, the aortic valve opens and the remainder of that contraction is used to eject blood from the ventricle. During this ejection phase of the cycle, the volume decreases rapidly while the pressure remains high because the ventricle is still contracting. Point 3 is the end of the contraction when the ventricle relaxes. When the pressure in the ventricle falls below the pressure in the aorta, the aortic valve closes. During the isovolumetric relaxation that follows, the ventricle relaxes and the pressure drops significantly, but since all the valves are closed, there's no change in ventricular volume. Point 4 is where the ventricular pressure has fallen below atrial pressure, so the mitral or the AV valve opens. This allows ventricular filling to occur again.